Alrighty, well, thank you for having me again. Today we're going to be talking about urology, which is uh, extremely important as a geriatrician, as an internist, and overall in general. It's really helpful to understand the normal aging of the bladder and so on, and the consequences of it. So we'll go ahead and start off with what is normal aging for your bladder and what should you expect. Lots of times you'll see older adults just considering urinary incontinence as a normal part of aging, both male and female, and that's not necessarily the case. So I jotted down, so I'm going to look down for a second to my paperwork here, key points, practical points for you to understand about the aging process, and then how it relates to complications of the bladder. So in general, the sensation that the bladder needs to be empty happens when the bladder is fuller than in a younger person. So practically speaking, a younger person gets that sensation that they have to void, but they can say, you know what, in Dr. Varano's lecture, and I think I can hold this urine for an hour. An older adult doesn't really get that notification where you can delay it for an hour. And if you do, it's definitely a challenge. The next normal aging is the bladder muscle contracts less forcefully. That's important when you're emptying out the bladder. For a younger adult, they certainly can void once before they go to bed and forcefully void and completely empty the bladder. The older adult might have some what we call post-void residual. So when we're evaluating individuals for overactive bladder, we ask them to go to the bathroom to empty out their bladder as much as they can. And then they come back into my clinic and I do an ultrasound to see how much urine has remained in the bladder immediately after they supposedly emptied it. So that's called post-void residual. And that happens as a result of the weakened bladder muscle. It just can't empty it. The urethral sphincter, which is the valve at the bladder outlet, is looser in older women. And so very similar to you hear about valves in your heart, where when it opens and closes, you can have a leaky valve and then you have a murmur. It's a similar thing with the bladder. The valves are not as tight. And so you certainly can have a drop or two of urine being lost. And that drop or two on an underwear for until it dries is extremely annoying. So it sounds insignificant, but it's definitely a distractor and annoying. The prostate gland certainly can become larger as you get older, and it's not uncommon for it to obstruct a urethra in men. And so when we're evaluating for urinary incontinence, we do a rectal exam to see if indeed the bladder, if indeed the prostate rather, is enlarged. And then we consider it being an obstructive force. There's a more frequent need to pass urine. And the reason why you have to urinate more frequently is because the bladder is a muscle. And just as your lower extremity muscles diminish in muscle fibers and strength, your bladder is a muscle that's aging, and it too is decreasing in strength. So you have that decreased force, but you also have decreased bladder size. And so you have to urinate more frequently because the amount of volume you can hold in the bladder is less. And then 80% of those 80 or older get up at least once in the night to pass urine. And although that is annoying, it still falls under the normal aging category because it's only once. When it becomes more than once, that's when it becomes pathological and something that needs to be addressed. But in light of the fact that you have weakened muscle fibers, shorter, smaller capacity, we accept one nighttime void within the normal aging process. So that's important. Now, why am I talking about this urinary incontinence as being such a big deal? Well, it's a huge deal. And I'm going to incorporate, as I'm talking about urinary incontinence, urinary tract infections and other complications also. But all those tend to overlap with incontinence. So incontinence is more than inconvenient. It definitely can be life-altering and can lead to individuals who are at the workplace early retirement. I've seen many men decide it's not worth it because coworkers are making comments that they're constantly in the bathroom. I see females also saying that coworkers would be complaining or criticizing that their frequent bathroom visits are their way of getting out of work, and that's not the case at all. They actually are voiding, but they void a small amount, and then they come back, and then they have to go again. So it really is disruptive, especially when you're in a meeting or you're conducting a lecture or something where it's not appropriate to say, "Excuse me, I have to go void." So early retirement is not uncommon, and social withdrawal. Social withdrawal has been such a huge problem because the social withdrawal, that social isolation, has led to many of my patients becoming depressed. So much so that in the local senior centers, I had many meetings with the administrators to have me give lectures on urinary incontinence, explain that it's not normal, explain the options they have, but just to have others feel more comfortable, we had incontinence products in the bathroom, both male and female. So that this way, if they do lose urine, they can certainly go to the bathroom, change their incontinence product, and go back to bingo or go back to lunch or whatever activity they were doing. So we don't want the individual to feel socially isolated or withdrawn because of the incontinence product. We want them to feel that it needs to be addressed. That's true. But in the interim, we're going to help them get back to that social activity. A lot of incontinence does lead to loss of independent function. And it's not uncommon for individuals to say, if I do go to someone's house, I know exactly where the bathroom is. Or if I do go to a public place, the first thing I ask is, where is the bathroom? If I go for a conference, or if I go to church, or if I go wherever I'm going that there's a large gathering or a large space, I make sure that I sit as close to the bathroom as possible so that when I have to go void, I don't disrupt everyone else. This is life-changing, and it shouldn't have to be that way because urinary incontinence, despite the public's opinion, is not normal biology of aging. We reviewed in the beginning of this lecture what is normal biology of aging, and losing your urine was not one of them. So 1 in 3 older adult female and 1 in 12 older adult males have lower urinary tract symptoms that include incontinence. So this is a very, very common condition. 6 to 10% of nursing home admissions are due to urinary incontinence. Now, why is that? it's because you're willing to take care of your loved one, despite the fact that they might have cognitive impairment at home. But when your loved one urinates on your brand new rug that you had installed the other day, or urinates in the kitchen, on the kitchen floor, or your new Oriental rug, or even your old Oriental rug. Those are very costly to have cleaned. And so it becomes such a burden that admissions to long-term care facilities as a result of urinary incontinence is extraordinarily common. And I know the statistics say 6 to 10, but in my clinical practice, I've seen much more, much higher admission rate to that. 22% of males with urinary incontinence seek help. Only 22%, probably because they're embarrassed, possibly because they feel that it's a normal biology of aging, or they just feel this is my destiny and that's the way it goes. 45% of females seek help for urinary incontinence. And in general, females are more willing to talk about issues that are that may be considered embarrassing as opposed to men. Okay, so what causes urinary incontinence? Here I am saying it's not a normal biology of aging. What could cause it? Well, quite a number of things can cause it. And if you're losing your urine, you should go through this checklist by yourself. You don't have to make a doctor's appointment, just go by yourself. And the first thing is, let's say a loved one is incontinent. The first thing you want to say is, what has happened? So if your husband, for example, was perfectly fine yesterday, and today he seems drowsy or he seems very confused, and you see that his pants are wet, those are two huge red flags. So why did he lose incontinence, and why is he confused? So it's somewhat of the what came first, the chicken or the egg. If an individual has a urinary tract infection, that urinary tract infection can certainly cause them to be uroseptic, in which the infection has gone into the bloodstream and has spread throughout the body, and now the brain is very confused and they become what's called delirious. So delirium is an acute confusional state, and often it's due to a infection which is reversible. So if you identify that this person has a urinary tract infection and you give them antibiotics to kill that infection, their confused state resolves and they go back to normal baseline of cognition. If, however, that individual does not have their urine checked, they very well may remain at home, remain untreated, and that delirium may be misdiagnosed as having dementia. And they might end up eventually in a long-term care facility because of the urinary incontinence creating a burden for the family, be admitted with a dementia diagnosis, and hopefully an astute clinician would evaluate them and state that, no, this person doesn't have dementia, this person has delirium, and delirium comes in three forms: hypoactive, which means they're very drowsy, like the person I was just describing; normoactive, which means they have no change in their activity level. So they're neither sleepy nor hyper, they're just their normal level, but they're confused, okay? So there's the hypoactive, the sleepy one, the normoactive, which is normal, and then the hyperactive, which is the one Hollywood loves. So they're overly dramatic and they're acting as if they're crazy, okay? So If the person has a urinary tract infection, that very well could cause delirium, and delirium in and of itself could very well cause the person to be incontinent. Okay. If they have a urinary tract infection, but they're not delirious, that too can cause an individual to be incontinent. They will have pain upon urination, or they could have pain. They could have burning with urination, and they could have urinary frequency. They're constantly going to the bathroom because that infection is an irritant to the bladder. And of course, they can be confused. Medications, a whole host of medications can cause an individual to have urinary incontinence, and it could simply be because of the urinary frequency and urgency that the medication is giving. So when you have either edema or high blood pressure and you're given a diuretic, the diuretic is designed to pull fluid out of the body and dump it into the bladder so that you can excrete it. Well, if your bladder is used to holding a certain number of cc's of urine, and now it's exploding because it is receiving a larger volume, well, your bladder doesn't know what to do. It gives you the signal, hey, you got to go, but then it's just going to contract so that it can relieve itself. Psychiatric disorders commonly can cause urinary incontinence. So we see young adults who are in a severe depression who are urinating all over themselves, and they simply don't care. They hear the signal, not hear, but they feel the signal of urinary incontinence, but they have no desire to respond to that. So they have no problems sitting in their own urine. Dementia. When you're cognitively impaired, especially dementia of the Alzheimer's type, the brain is broken and there's a tremendous disconnect between what your organs are saying and how your brain is processing that signal. So if your stomach is saying, I'm hungry, I'm empty, your brain in an Alzheimer's individual might not recognize that hunger pain as such. And the victim of Alzheimer's disease might be screaming or might act out and punch others or bite or be just overall aggressive. And they're aggressive because they're what we joke around and say hangry. So they're hungry and angry. Their anger is due to their hunger. In dementia patients, they can't tell you they're hungry. Same thing with the bladder. So they have the bladder contractions. The bladder says, I'm full, and is working. The bladder is working. It sends those signals to the brain to say, you need to find a bathroom and void. Unfortunately, the broken brain of the Alzheimer's patient can't process that. So they don't understand what those signals are. But they do understand that it's uncomfortable. And as the bladder increases in volume, that individual, once again, will act out. And they might scream, my belly hurts, or I'm in pain, or they might not use vocabulary at all in the latter stages of Alzheimer's disease. They might just, once again, bite someone, hit someone, throw a piece of furniture, act out because they're in tremendous amount of pain. And then the next thing you know, their pants are soaking wet. And that behavior has now changed. So the discomfort of the bladder enlarging and them getting the signals and feeling that fullness, they acted out on that. Now that's gone, but now their pants are soaking wet and they're extremely uncomfortable because they have urine down their legs, in their socks, in their sneakers, in their shoes. So that now triggers another set of behaviors. Stool impaction. Stool impaction is a cause of dribbling. And it's fascinating how the chicken and the egg story with geriatrics will go over and over and over again on so many different syndromes. A lot of older adults have urinary frequency, urgency, and sometimes incontinence. So urinary frequency, they go to the bathroom often. Urgency, they feel that sudden sensation of, I gotta go, I gotta go, I gotta go. And if they don't get to the toilet in sufficient time, then they lost control and now they're incontinent. So a lot of individuals who have urinary frequency, urgency, and incontinence, if they know that they're going to take a plane, if they know that there's a social activity at the assisted living that they want to attend, or a wedding, or a religious activity, whatever it may be, they know that what goes in goes out. So they're very smart and they say, well, I don't really want to wear an incontinence product under my dress. I don't really want to have to feel that urge of voiding and destroy my time or interrupt a funeral to run to the bathroom. I will deliberately and intentionally restrict my fluid intake. And the goal of that is, if I could decrease what goes in, I could decrease what goes out. So that may work, but there's always a reaction to some kind of action. So you're planning on restricting your fluids. What does that do to your body? Well, that does a lot of things to your body. If you restrict the fluids, one, you can easily become dehydrated. And if you become dehydrated when you're going from sitting to standing, there's not enough volume in your blood vessels that you're not going to get the blood necessary to perfuse your brain. And your brain will say, I'm dizzy. And you will see that the room is spinning around you. And so you have to respect your brain. If your brain is saying, I'm feeling dizzy, it's clearly telling you you're not hydrating me. So what you need to do is sit down, grab some water, or if you don't have any water, ask somebody to bring water to you and hydrate yourself up before you stand up again. Because I guarantee you, if you ignore your brain saying, I'm feeling woozy, from going sitting to standing, it will have you drop, because going from sitting to standing drops your blood pressure, and it's called orthostatic hypotension. So you're hypotensive. And if you're not going to oxygenate your brain by hydrating yourself and getting the blood up there, the brain is going to tell you to fall. If you then collapse, you faint, you're on the ground, you're completely flat, blood will flow, because now gravity is eliminated. So blood will flow to your brain. Once your blood has flown to your brain and your brain gets oxygenated, you wake up. But the problem is now you wake up and you have a broken hip, you have a broken nose, you have a bleed in your brain because you fell and hit your head, you have a broken wrist. So the consequences are tremendous. What else happens when you dehydrate yourself? Well, when you dehydrate yourself, you're not only decreasing the fluid in your bladder, not only decreasing the fluid in your vessels, but you're decreasing the fluid in your intestines. And normal biology of aging is that your intestines become more sluggish. They're slower as you get older. So you really want to exercise. And when you exercise, the physical movement moves the intestines, and the intestines get stimulated, and they contract and push the stool down so that it can exit your body. But if you're restricting your fluids, the stool will your body will reabsorb any fluids that are in the stool because it's trying to stay hydrated. So your stool will become harder and you can get constipated. And when you get constipated, there's a lot of complications with that. Complication number one, if your intestines are full of stool, it can certainly push on to that stool impaction can certainly push on the surrounding organs and can cause dribbling. So you will have urinary incontinence as a result of the stool impaction. The second problem with restricting your water to avoid urinary incontinence and actually causing urinary incontinence because of the dribbling is that once you have constipation and you are trying to now forcefully push this dry stool out, you're pushing and you will probably create hemorrhoids, either internal hemorrhoids or external hemorrhoids. Now, those hemorrhoids can certainly bleed, and it's very scary for patients. They might think that they have a cancer, or it can be extremely scary when you have a large hemorrhoid that bleeds and breaks if it's internal or external. If they're external, they can be itchy, they can be painful, they can be burning, and then trying to medicate them with either preparation H or witch hazel pad in that sensitive area is extremely challenging. Okay. Furthermore, when you strain yourself in order to have a bowel movement in stool that is hard, that straining mechanism of action is altering your blood flow and so you're valsalvating. And what you could end up doing is causing such huge fluctuations in your blood flow that some people even faint. Okay. Lastly, the third complication is as we get older, our bones are not as robust as when we were younger. And so osteopenia, osteoporosis, decreased quality of bone matrix is very common. And if you're straining and you're putting all this pressure, it is not unheard of to have a pathological spontaneous vertebral fracture. And you now have fractured one of the vertebrae, and that is extremely painful. Then in order to treat that pain, it's not uncommon that individuals are given narcotics. Narcotics will cause you to be constipated. So it's this chicken egg situation in which, if we go back to the story, you restricted your fluid intake because you had urinary frequency. And what did you end up doing? You ended up causing your stool to be dry, constipated, ended up causing urinary incontinence with dribbling, ended up causing possibly a cardiac arrhythmia, a fainting spell, a compression fracture. So hydration is absolutely critical, even if you have to have a urinal with you, even if you have to wear pads. Okay, so this is an extremely important situation. Now, I took some other notes that I wanted to share with you before I forget. Okay, so I had mentioned earlier that medications could cause worsening of urinary incontinence or could cause urinary incontinence. And Lasix being, one of the biggest diuretics offenders of it, but there's others. Alcohol. So lots of times individuals feel that they can't sleep at night. and they get up. And while they're up, they might as well void. So they self-medicate with alcohol. Now, alcohol will sedate you, it will put you to sleep, but unfortunately you have a rebound insomnia, and alcohol is a diuretic. And so the alcohol will cause you to urinate more frequently at night. And there's a little trick that bars do. They offer you complimentary pretzels, salted pretzels, and salted peanuts. And the reason why they do that is because salt retains water and causes you to be thirsty. So if you're at a bar and they just offered you salty pretzels and salty peanuts, the chances are you're going to say, can I have another beer? Can I have another alcoholic beverage? And because alcohol is a diuretic, you're then going to go to the bathroom and come back and kind of repeat that whole cycle, okay? The next offender is caffeine. So a lot of individuals really don't appreciate how much caffeine they consume during a day, and that can absolutely lead to urinary incontinence. In addition, caffeine can lead to gastric upset, like a gastritis. It could be viewed by the body as an irritant. Opioids can certainly cause worsening urinary incontinence, benzodiazepines, some antidepressants like tricyclics, and allergy medications such as antihistamines and decongestants. So there are quite a number of medications. Now, these are classes that I just shared with you. I didn't share with you specific names, and I did that intentionally because I highly encourage, and I've encouraged in multiple lectures, that you take your medication list and you go to your local pharmacist and you share with your local pharmacist your concerns about drug-drug interactions, about your age and how the medications are being cleared. Is it renally cleared, hepatically cleared? And what are the consequences of these medications? And is there any way that I could either take them all at once or spread them out? Is there any contraindication in taking them all at once? Is there any benefit in spreading them out? And so on and so forth. And I encourage you to take those medications to your pharmacist and say, I have incontinence. Are any of these medications or a combination thereof a contributor to this condition that I'm experiencing? And let them run it through. Let them run it through their computer system and review the mechanism of action and if it's causing the symptoms that you're experiencing. Okay, so incontinence and physical activity. It's a two-way relationship. So those who are incontinent are less likely to be physically active. Why? Because they know if they're going to get up and they're going to move around, they're probably going to lose their urine. Okay? And those who are less active are at higher risk for incontinence. So individuals who are overweight or obese don't feel they have the energy or ability to get up and run around and so on. So they're less likely to move around, and they have a higher risk for incontinence. So those who are incontinent are less physical, and those who are less physical are more incontinent. So those are some, key points that I wanted to share with you. It's because it's 3:38, and I do want to leave it for some question and answers. But key points before we turn to the question and answers is let's go over what types of incontinences there are. so that when you talk to your physician, you know what to do. So some key points. So you're losing urine, okay? The physician's gonna ask you details because he or she is going to diagnose the type of incontinence you have. So my recommendation is you create a bladder diary from when you wake up in the morning. Do like a couple of days. If you want to do a week long, that's great, but a couple of days is fantastic. And the questions that the physician is going to ask is, how many times do you urinate at night? How many times do you urinate during the day? What if you're urinating, if you complain and say, I'm urinating 4 times at night, the next question is going to be, do you wake up and because you're awake, you figure I'm going to go void? Or do you wake up because you feel your bladder is contracting and you have to void? So is your bathroom visit at night as a result of you being awake, or is your bathroom visit at night what had awakened you? Okay, that's a critical differentiator. Then in the bladder diary, they're going to ask you what time did you take your last beverage? What was your last beverage? Was it water? Was it juice? Was it coffee? Was it alcohol? So those details are going to be critical. Okay. The types of incontinence are, we'll do it we'll just kind of pick it out. We'll do it stress first, okay? Stress incontinence can occur at any age. And typically it's a female who had a child, a natural childbirth, so a vaginal delivery as opposed to a C-section. So the child had to go through the birth canal and altered and perhaps caused damage as the child traveled through the birth canal and exited. Individuals who've had vaginal births and don't retrain the pelvic floor muscles by doing, some people call them Kegels, some people call them Kegel exercises. They have weakened pelvic floor strength. So what happens is you can have a 20-year-old, an 18-year-old, a 13-year-old. Anyone who has the ability to have a baby, regardless of your age, who doesn't do the Kegel exercises and strengthen that pelvic floor, if they're laughing, jumping, sneezing, coughing, any alteration in that type of pressure will cause them to leak. And that will be a lifelong problem. So if you have a 16-year-old girl who's pregnant and has a baby at 17, from 17 until she passes, unless she addresses it, she will always have stress incontinence, okay? The Kegel exercises are successful if done properly, but it's very difficult for me to explain which muscles to contract. So it's highly recommended that you review which muscles are proper for you to contract by going to see a gynecologist. And the gynecologist will do an exam and will explain to you and will give you tricks, and there's even certain devices that you can use to ensure that you are contracting the proper muscle. Okay. Then there's, so that's stress incontinence. Then there's urge incontinence. Urge incontinence gets a lot of attention as far as commercials go, and as far as advertisements, not only on the TV, but magazines and news and radio and whatnot. Urge incontinence is, as we said earlier, a younger adult gets a lot of warning. They could have received a contraction an hour ago and you could still hold the urine. An older adult gets warning, and at that point they're almost full. So they don't have that luxury of time to suppress it. So urge incontinence, you get the urge and it says, I gotta go. And what happens is, I gotta go, I gotta go, I gotta go. And if you don't get to that bathroom in the time that your bladder wants, you now become incontinent, okay? So that's urge incontinence. That's an overactive bladder. Now, there's things you can do non-pharmacologically to control those waves of contractions. And basically, the only way that I can kind of bring this to light for you is if you've ever, so here's a classic example. You're driving on the highway, okay? You're driving on the highway and you see rest stop. Next rest stop is going to be, I don't know, 20 miles. So this is the last stop before that 20-mile stretch. So you decide, you know what, I might as well get some gas. You never know what's going to happen. Let me get some gas. So you pull over, you fill the tank. Now, that's the only reason why you pulled over, is just because you saw the sign and you filled the tank. You're filling the tank, and then all of a sudden you see a big Greyhound bus coming. And the big Greyhound bus comes, and out comes seniors who just went to a casino. And the bus is bringing them to the rest stop so that they can empty out their bladders and stretch and so on and so forth. So now you see all the seniors exiting the bus and you're like, they're probably going to the bathroom. I guess I'm here. I might as well go too. Okay? By the time you finish pumping your gas, park your car, go inside, there's a huge line for the female bathroom. Males, not so much. Females, huge line. So you get on the line. Now, mind you, you never had to go to the bathroom, but you're on the line. And as you get closer and closer to the bathroom sign, your bladder starts to contract and starts to say, hey, I got to void. I got to go. Hey, I got to go. I got to go. By the time you actually get into your stall, you feel like if I have to wait 1 second more, I will lose my urine. And you have this urgency, okay? So what happened? Physiologically, you did not increase the volume of your bladder. You didn't tell me you just consumed 12 ounces and waited a few minutes or nothing. There was no change in PO intake, by mouth intake. It's your brain seeing that there is a sign saying, this is an opportunity to void. So your brain recognizes the bathroom, the universal bathroom sign for males and females, and it knows that that sign means to void. So it starts contracting. Okay? If you give in to those signals and say, oh, you're right, I gotta go, I gotta go, I gotta go, you very well could become incontinent. But if you do biofeedback and mind over body and say to your brain, hey, I understand you want to void, but we're going to visualize these contractions going away, and we are going to control ourselves until we get into the stall. So if you visualize those contractions going away and you're able to decrease them, then you're able to walk, not run. You're able to take off your garments, not rip them off. And you're able to void and not be in a panic mode. Okay? So that's extremely helpful. And there are places that you can learn how to do some biofeedback and non-pharmacological interventions on how to decrease the urinary frequency, urgency, and so on. So that's urge incontinence. So we did stress incontinence, urge incontinence. And then for men, the prostate certainly can enlarge. And when the prostate enlarges, it's an obstruction. And when it's an obstruction, you have urine backed up in the bladder contracts, the gentleman goes to the bathroom, he voids a couple drops because that's all that can exit because the prostate is constricting the outflow. He leaves the bathroom, and as he's walking a couple 100 feet away, he has to go back to the bathroom and void again. He never emptied out his bladder. Okay? So that's overflow incontinence. Then there's functional incontinence, and functional incontinence is your inability to get from point A to point B. So you physically can't get from your position to the bathroom to void properly. Who's that? Those are individuals who are in wheelchairs. Those are individuals who are cognitively impaired. Those are individuals who have like Down syndrome or mentally, not necessarily Alzheimer's or those types of cognitive impairments, but have a hard time understanding for whatever. There's a whole host of conditions in where they can't understand that they have to get to the bathroom fast. So functionally, whether it's physically, whether they have diabetes, whether they have assisted devices, whether they have a bad back or a walker or a wheelchair, a cane, whatever it is, there's a functional limitation to getting from point A to point B. Okay, so those are the types of incontinences. And your physician is going to ask both for the bladder diary and is going to ask questions to determine which type of incontinence you have, okay? And then based on that, they will either prescribe exercises, they might send you to a urological clinic for feedback. They'll ask you to restrict your fluids before you go to bed, but always have a little glass of water by the side. So if you wake up and you're dizzy, you can rehydrate yourself. And then ultimately, they might prescribe medications. Now, once they prescribe the medications, you want to ask, will this cause me to be confused? What are the side effects of these medications and what are my medication options? And then you can make a joint educated decision as to what you want to do, okay? So it is 3:50 and I want to leave 10 minutes for any questions and answers. So I'll go ahead and open it up to anyone who has questions or concerns.
Susan, you talked about an ultrasound. What are the standards post-void residual? What is normal? What is too much? When is it a problem?
Right. So typically, there's tolerance for how much urine should be left in the bladder. And they will, male versus female and so on. So it's very predictable as to what's acceptable or not acceptable. You want to basically empty out the bladder as much as possible. But what they'll do is they'll say, okay, you have 20 cc's left or 100 cc's left and whatnot. And they'll do multiple post-void residuals to see if that's a consistent pattern. And then they'll also see how much, they could very possibly see how much what is your bladder capacity? So how much can you hold, how much are you voiding, and how much are you retaining? So when you do go for the bladder ultrasound, they'll share that with you once again, based on if you're a male or female or whatnot. But ideally, you want to have as little urine in the bladder as possible.
Thank you.
You're welcome. Any other questions?
Are you ready for another question?
Yeah.
74-year-old man with a history of prostate cancer and radiation, 44 sessions of radiation treatment to deal with that. My question is, I've got urinary issues. My question is there a chance that in the process of receiving those radiation treatments that my bladder was damaged, shrunken, or whatever, because I do not seem to have capacity, and when I urinate I don't seem to get much output. So I'm curious, I'm going to be seeing my own urologist in about 2 weeks. But this opportunity to possibly speak with you popped up all of a sudden. So I have what is potentially my situation, because in the dim past, I recall the days when everything seemed to be normal. I didn't have to urinate as often. And when I did, I had a greater volume. And when I was done, I felt like I had voided everything that should have been gone. But now it's a totally different thing. I can do